Good afternoon. On behalf of Immunexpress, it's my pleasure to welcome you to the Industry Insight session that we will be sharing with you to discuss the role of a clinically validated host response test, SeptiCyte RAPID, to differentiate sepsis from SIRS. Our speaker today is Dr. Robert Balk, who is the Professor of Medicine at Rush Medical College and Director of the Division of Pulmonary and Critical Care and Sleep Medicine at Rush University Medical Center in Chicago. He has several other titles, which you can see listed here, and many responsibilities. His major clinical and research interests have been focusing on understanding the pathogenesis and defining management strategies for patients with sepsis, septic shock, acute respiratory distress syndrome, and multiple organ dysfunction. And without further ado, I will let him begin his presentation.
Thank you for that kind introduction. Let me first point out I do have some disclosures and am receiving an honorarium for this presentation, and also point out that while I was a member of the Sepsis Definition Conference number 1 and 2, I'm not a member of Surviving Sepsis Committee or the Sepsis 3 Definition Conference. Let's move to our objectives for today. And that is, we want to define sepsis and septic shock, review the incidence and epidemiology of sepsis and septic shock, and spend some time discussing the challenges to making a timely diagnosis of sepsis and the risks as well as benefits of indiscriminate antibiotic usage. And we're going to spend some time describing a rapid sepsis diagnostic approach using the SeptiCyte RAPID assay. Well, the good news is that through a lot of efforts, sepsis is no longer in the top 10 leading causes of death in the United States for adults, at least as far as the year 2020. But if we look at that list of top 10 causes, we see that COVID is number 3. Influenza and pneumonia are listed as number 9. And I would give to you that if you die of COVID, influenza, or pneumonia, you probably had sepsis, which makes me wonder why sepsis is not in the list of the top 10 causes of death in the United States. In 2017, it was estimated that there were 1.7 million episodes of sepsis in the United States, and up to a third of the deaths in hospitalized patients in the US are reportedly as a result of sepsis. Now, this is a distressing outcome when you think about this excess mortality rate, when we have increased sepsis awareness, we have guidelines, we have treatment bundles, we have a number of broad spectrum antibiotic regimens, and in fact, we have encouragement through these bundles, through administrative oversight, to initiate early aggressive antibiotic therapy, yet we still have excess mortality. And sepsis is extremely expensive, costing over $60 billion a year to take care of patients with sepsis. And unfortunately, survivors still have adverse sequelae with increased morbidity, increased readmission risk, and even increased mortality over the subsequent years. So what definition should we use for sepsis? And this is where it gets extremely confusing, because there are diagnostic, clinical, research, billing, and administrative definitions that are all different and all attempting to meet the purposes that they were developed for. Sepsis has been around a long time. It goes back to the time of Hippocrates, when we talked about a process that was associated with rotting, with death, and through the early 70s, 80s, sepsis was almost synonymous with having bacteremia, having shock present. And it wasn't until the early 90s that we came up with consensus definitions, the SIRS definition that then metamorphed into sepsis 2, and subsequently we now have sepsis 3 definition. But there's also ICD-9, ICD-10 codes, which are different. And then there are some administrative definitions, which we use to judge our ability to recognize and effectively treat sepsis. the current Sepsis 3 International Consensus Conference definition is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And how we can define that is that we recognize that as a consequence of an infection, the SOFA score has increased by 2 or more points. We can also see that if we define a group of patients with sepsis that has shock manifested as persistent hypotension requiring vasopressor administration in order to maintain a mean arterial pressure greater than or equal to 65 millimeters of mercury, also accompanied by an elevated serum lactate, after adequate resuscitation, that this defines septic shock and has an associated mortality that exceeds 40%. So we have a challenge, and the challenge is to make a timely diagnosis of sepsis in a time when we do not have a gold standard for diagnosis, and recognize that if we delay the diagnosis of sepsis, we potentially delay institution of effective antibiotic therapy and other support strategies, and this can result in increased mortality and increased costs. And unfortunately, what we currently have with either the SIRS criteria, the new Sepsis 3 criteria, using lactate, using white cells, is we have a definition that actually still lacks specificity and sensitivity. And we can't rely on positive blood cultures. First, positive blood cultures can exist in patients who are not septic. Second, we know that of septic patients, less than a third have positive blood cultures, and other biomarkers such as CRP, procalcitonin also lack specificity. And even if we look at positive any culture, we realize that that is not the be-all, end-all answer, since a lot of our sepsis patients do not have positive cultures, and even a positive culture doesn't tell us antibiotic sensitivity testing results. So we are left with a conundrum of how can we make a timely diagnosis and start effective antibiotic therapy. And the challenge is that we need to discriminate what is non-infectious inflammatory syndromes from sepsis, which does definitely require antibiotic or antimicrobial therapy. And we know that cultures are not the answer. We know that we need to follow some algorithm in order to start effective antibiotic therapy within 1 to 3 hours when needed. But we also know that with antibiotic stewardship and multi-drug resistant organism concerns, that indiscriminate use of antibiotics is going to be detrimental. So we can't give antibiotics to everyone who might have sepsis without paying a price. So what we need for sepsis is a precision medicine management plan. And that may involve coming up with better guidelines and hopefully a gold standard diagnostic sepsis test. Well, I mentioned the Surviving Sepsis Campaign, and they have a recent reiteration of the guidelines that came out in 2021. And they have now realized that indiscriminate antibiotic usage may not be the answer for all patients with sepsis. And you can see from their updated guidelines that certainly for those patients who you have a strong suspicion of sepsis, especially if it's septic shock, they encourage early initiation of broad spectrum antibiotic therapy. And this is strong recommendation, although the quality of the evidence is still low quality, and especially when the patient is not in shock, it's very low quality. But if you're not certain a patient has sepsis, then maybe there's a time for pause and to rethink, to continue the investigation, that you don't have to start antibiotics, or if you start antibiotics, you don't have to continue antibiotics. And these subsequent recommendations go into those likely scenarios where you're not sure the patient has sepsis, and they encourage a period of time, call it a time limited, you have up to 3 hours to investigate, get data, see where is the potential site of infection, what is the potential source or cause of infection, what kind of antibiotics should be needed, or what are alternative diagnoses which may be more strongly suggestive of what's causing the clinical picture you think could be sepsis. On the next slide, we take that one step further, and once we've made a decision to start our antimicrobial therapy, we don't have to always start broad spectrum. I think we now have, again, the opportunity to consider what are the likely organisms, what are the likely sites of infection, and knowing the antibiogram, what would be the most effective strategy. So not everybody needs MRSA coverage. Not everybody needs antifungal coverage. What this is encouraging all of us to do is to think of our patient critically and decide what is the best reasonable regimen to start at this period of time. Next slide. And then even once you've made the decision to start antibiotics, it encourages us to use pharmacokinetic, pharmacodynamic principles in order to give the right amount of antibiotics to the individual patient for their individual clinical circumstance, to do effective and appropriate source control when needed, and don't continue your antibiotic therapy forever. Find the optimum treatment, which may be a guideline that helps you know that. Maybe it's based on their clinical response and the results of therapy. And if you really don't know, perhaps combining procalcitonin with clinical acumen and clinical response will help you determine the best amount of treatment to provide to your patient. Next. So we need to move into antibiotic stewardship. And while we're under the gun to provide effective antibiotic therapy as soon as possible, especially in septic shock, where we have golden hour, golden minutes of opportunity to try and intervene to improve outcome, we also need to be cognizant that we need to avoid giving unnecessary antibiotics. We don't want to fuel antibiotic resistance, and we don't want to create antibiotic-associated complications. We also need to be mindful that we got cultures for a reason. We want to see what the culture and sensitivity results are, tailor our therapy based on those results, and de-escalate our therapy as the patient clinically improves. And while no one argues with the need for treatment, we don't want to be guilty of overtreatment. The data in support of giving early antibiotics is actually a little bit old right now. It comes from the early 2000s, and this classic study by Kumar and associates, one of the sites was actually my own institution, where it was shown in patients who have hypotension associated with presumed sepsis that delays in antibiotic therapy are associated with increases in mortality. If antibiotics are given, and I should emphasize, appropriate antibiotic therapy is given, within the first 30 minutes, survival in hypotensive associated sepsis was 82.7%. But if you wait 6 hours before appropriate antibiotics are administered, survival drops down to 42%. And unfortunately, about half of the patients in this retrospective study didn't receive their antibiotics until after 6 hours of hypotension. Next slide shows us that even as recently as 2017, the longer you delay the administration of appropriate initial antibiotic therapy, the higher the rate of developing septic shock. So even if the patient is not in shock and you are not on top of giving appropriate antibiotics, you run the risk of putting that patient into a picture of septic shock, which we've already said increases expected mortality. Now, we rarely have people do a study where they're going to withhold antibiotics. So this is an interesting quasi before-after observational study of adults at the University of Virginia Surgical Intensive Care Unit, where if the picture was not clear as to whether the patient truly was septic, they had an aggressive approach 1 year, followed by a conservative approach the subsequent year. And in the conservative approach, instead of just starting antibiotics when somebody might be septic, they decided to accumulate data, to look at what the information suggested and decide not only do they need antibiotics, but what would be the most appropriate site of infection, cause of the infection, what kind of antibiotic regimen should they give. And it turned out that being conservative actually decreased all-cause mortality. It dropped from 27% to 13%, decreased the duration of antibiotic therapy, and increase the likelihood that the patients received initially appropriate antibiotic therapy. So this actually does support some of the recommendations that come from the recent Surviving Sepsis Campaign recommendation. And the antibiotic decision is far from an easy one. You have to decide, when do you want to start your antibiotics, what order, how are you going to infuse your antibiotics, bolus, prolonged infusion, continuous infusion, and what kind of special dosing considerations. So if they have augmented renal clearance, if they have a large volume of distribution, if they're getting some sort of renal replacement therapy, they're on ECMO, all of this may impact the outcome and success. And even the simple decision of, do I start my gram-negative antibiotic first or my gram-positive, may have implications. If you choose the wrong first antibiotics, you are delaying the time to your appropriate antibiotic therapy. And if it wasn't complicated enough, we have quality standards. Here we see CMS has put together their sepsis management quality with a 3-hour and 6-hour bundle. And it's important for you to remember, because if you don't, I'm sure your hospital administrators definitely remember, that the quality of care, the patient outcome, your resource utilization, reimbursement, revenue, maybe even your reputation and those all important hospital rankings depend on how well you meet these criteria from an administrative standpoint. So what we need is a better strategy to early detect those patients with sepsis. And there's a lot of stuff out there. We have electronic databases, artificial intelligence, a slew of different biomarkers, and you can do combination approaches, use big data, use biomarkers, trying to come up with what is an effective, appropriate sepsis test. And looking at what we've seen over time, a lot of places have been using procalcitonin. And here's some procalcitonin data to help differentiate SIRS from sepsis. And you can see the area under the receiver operating curve gets as high as 0.85, which is reasonably decent. But it still means 15% of the time you may be wrong. And it also is a test that is helpful, but you always need to consider the history, physical exam, clinical data, and other criteria in order to help make that diagnosis. Let's move to the next determination, and that is something called SeptiCyte LAB, which is a whole blood expression of 4 genes on white blood cells that go along with the response to a infection that we could then say is a cause of sepsis. And this was a study that was clinically validated across 4 sites and across 8 sites, and ours was one of those sites, in 447 adult ICU admissions. And this test, which did meet FDA clearance in 2017, was able to identify 4 bands with likelihood of sepsis, and the area under the receiver operating curve in this case went from 0.82 to 0.89. And this did receive FDA clearance and approval, but it wasn't commercialized due to workforce complexity and a 6-hour turnaround time. Which brings us to the discussion of the SeptiCyte RAPID, a new technology using 2 of those genes that are on the white blood cells to hopefully differentiate patients with non-infectious SIRS from sepsis within a 1 hour time period. This test is independent of the type of pathogen causing sepsis. That could be gram-positive, gram-negative, viral, fungal, yeast. It's not reliant on finding the pathogen in the blood. And it, again, will use the 4 different bands, a septic score from 0 to 15, which can translate into the clinical risk of the likelihood of having sepsis. So the SeptiCyte RAPID, we've already talked about. It did receive 510K cleared FDA host response test as a way to help diagnose sepsis. It uses reverse transcription, elimination chain reaction on the blood sample that is collected in PAXgene blood tubes. It's used in conjunction with clinical assessment, vital signs, laboratory findings to aid in the differentiation of infection-positive sepsis from infection-negative systemic inflammation. And this score will fall within one of these 4 discrete interpretation bands, as we'll see subsequently. And we'll see as Dr. Davis goes into practical application in the second part of this industry insight discussion. And this SeptiCyte RAPID is intended for in vitro diagnostic use using the Biocartis IDELA system for analysis. How the SeptiCyte RAPID was validated was done in a 2-part fashion. One is retrospective evaluation of the prior Venus-Mars database, which incorporated 356 subjects that were enrolled in these 2 observational clinical trials, and using those previously banked samples, were able to then reanalyze and use the retrospective physician diagnosis consensus comparator to see how well that correlated. But there also was a Neptune trial, a prospective evaluation that processed samples in real time from 3 sites, University of Southern California, our site, Rush and Emory University, and used clinical samples with rapid on-site evaluation. And the treating clinicians were blinded to the results, but there was still a retrospective physician diagnosis consensus to help adjudicate the results at the end. And here's the complete study, and you can see we have a forced result, consensus result, or unanimous result based on how the retrospective physician panel put things together. And you can see discrete bands of the 80% confidence interval of the probability of sepsis. And obviously, if you're in the band 4, it's pretty high likelihood that that patient has sepsis. And if you're down in band 1, it's very low likelihood the patient has sepsis. And those are the non-infectious systemic inflammatory response patients. Here, putting that in a little bit better perspective, you can clearly see our 4 bands, band 1, 2, 3, and 4, and the width of those bands. And you can see that band 4 with the SeptiCyte interpretation score from 7.4 to 15 has a high risk of sepsis. You can see 81% of those patients were diagnosed with sepsis, a sepsis likelihood ratio of 6.05. Band 1 from 0 to 4.9 has a very low risk of sepsis. You can see it's only 9% likelihood of sepsis, which a likelihood ratio of 0.15. And then band 2 and band 3 subsequently increased the potential to have likelihood of sepsis. But band 1 and band 4 clearly stand out as ways to either make a diagnosis or eliminate a diagnosis for a patient having a likelihood of infection-related sepsis. And here we see the band put into a probability of sepsis curve, and you can see our cohort, sensitivity, sepsis probability, surge probability, and likelihood ratio displayed from band 1 to band 4. and realized the end test performance was consistent across both the retrospective as well as the prospective real-time testing from the clinical studies we just talked about. And it's important as you look at a test to make the diagnosis of sepsis versus non-infectious systemic inflammation that we don't take it as a score in isolation, but we also put into perspective other clinical variables which often shape our clinical impression. And if we look at how the SeptiCyte RAPID score performed, it also worked better than clinical variables alone. It worked better than procalcitonin plus clinical variables. And if you add SeptiScore plus procalcitonin plus clinical variables, it worked even better. So the SeptiCyte RAPID score taken in conjunction with the clinical acumen you bring to the patient's bedside can help you effectively make a diagnosis of somebody with sepsis versus somebody with non-infectious systemic inflammation. And our score again, bringing out the high risk of sepsis in the band 1 versus band 4. And here we see a likelihood ratio from the real-time prospective clinical study. The likelihood ratio was 7.26 in band 4. The likelihood ratio was 0 in band 1. So this is the real-time prospective clinical study we just talked about. And again, results occurred within 1 hour. Now, looking at the receiver operating characteristic curve and the area under that curve as we go from the forced to consensus to unanimous RPD diagnosis of sepsis, you can see the area under the curve increased from 0.86 to 0.95, which is really a remarkable ability to help differentiate sepsis from non-infectious systemic inflammation. And you can see that the SeptiCyte RAPID easily differentiates from procalcitonin, from lactate, or from white blood cell in order to differentiate sepsis from SIRS. In the recent application of the SeptiCyte RAPID to patients with COVID-19, not all patients with COVID-19 manifest as a sepsis picture. And here you can see from these 6 cases that the patient who manifested a systemic inflammatory type condition without an infection had a band 2 SeptiScore, whereas those who had more clearly defined sepsis were in band 3 or band 4. And looking at how procalcitonin would perform in these scenarios, procalcitonin performed well in the band 4 patients, but clearly did not pick up the band 3 patients. Next slide. Looking at patients with SeptiCyte RAPID and culture-confirmed infection in the urinary tract or blood cultures, you can see that those with UTI and blood culture positivity met mostly in band 4. There was 1 in band 3, and there was one with both UTI and blood in band 3 and band 2. And there was only 2 people who had a UTI who were in band 1. And it's likely that patient did not meet the RPD diagnosis of sepsis, but would have had the urine infection without a systemic inflammatory response that would have made for a sepsis diagnosis. So what we've seen from the SeptiCyte RAPID tells us that we have a test that may help us make a diagnosis of sepsis from non-infected systemic inflammation. The result is not to be used in isolation. We need clinical, laboratory data, and other support to help us with the interpretation. There's no data at this time regarding its prognostic ability, the value of serial testing, or whether it aids us in the duration or even the initiation of antibiotic therapy, and the ability to assess the severity of illness or triage. And testing and results precede treatment and potential impact of treatment to correct or timely impact the outcome of sepsis. So all that is data that will be hopefully forthcoming in the future. Summarizing what we've talked about with SeptiCyte RAPID, the Sepsis Score strongly discriminates sepsis from infection-negative systemic inflammation, so-called SIRS. It did receive FDA 510(k) pivotal approval. The test performed consistently across both the retrospective bank samples and the prospective real-time testing clinical samples. It outperformed other commonly measured clinical parameters like lactate, procalcitonin, and the white blood cell count. And in patients with positive microbiological analysis, such as the urinary tract infection, blood culture positivity, COVID-19, the sepsis score seemed to correlate very well with the sepsis diagnosis that the retrospective physician diagnostic group came forward with as far as their interpretation. So in summary, sepsis is increasing. It's associated with high morbidity, high mortality, and a high cost of care. What we truly need right now is the ability to help our early recognition, our early diagnosis of sepsis so that we can achieve our quality outcomes, improve our patient outcomes, and better make our antibiotic initiation and other support therapy decisions in a timely fashion, not only to meet quality metrics, but to help our patients' overall outcome. And a rapid, effective test to help differentiate sepsis from non-infectious systemic inflammation has the potential not only to enhance antibiotic stewardship, but also to impact the increasing problem with multi-drug resistant organism infections that is continuing to plague our healthcare system. With that, let me thank you all for your attention, and we'll have time for questions at the end of Dr. Davis's presentation. Thank you.
Thank you very much, Dr. Balk. And now Dr. Roy Davis will be speaking about the role of SeptiCyte RAPID in the clinical workflow and touch upon the alignment with these 2021 Surviving Sepsis Campaign guidelines and CMS Core Measures. Dr. Roy Davis has 30 years experience in including neonatal and pediatric critical care. He currently serves as the CMO at Immunexpress, but previously served as CMO at Providence, Alaska, where he assisted in implementing the Muse and sepsis surveillance programs, which were then rolled out across the Providence Health Services. And with that, I will go ahead and let Dr. Davis speak to the SeptiCyte RAPID in the clinical workflow.
Thank you, Jane. And thank you, Dr. Balk, for that very interesting and expertly discussed presentation. In the preceding presentation, Dr. Balk expertly discussed the difficulties associated with the diagnosis of sepsis and the clinical validation of SeptiCyte RAPID, a host response diagnostic for systemic inflammatory response due to infection or sepsis. In the next 15 minutes, I would like to discuss briefly, review some of the significant changes in sepsis management, as reviewed by Dr. Balk, published in the 2021 Surviving Sepsis Campaign's Sepsis International Clinical Management Guidelines, and discuss how we see a role for SeptiCyte RAPID in aligning with, and helping drive compliance with these guidelines. I will review how SeptiCyte RAPID can be used in the clinical evaluation of suspected sepsis patients in impacting the diagnostic uncertainty, appropriate early intervention, and antibiotic and diagnostic stewardship. Finally, I'd like to close by presenting two case studies as examples of the use of SeptiCyte RAPID in the clinical environment. Dr. Balk reviewed in detail the Surviving Sepsis Campaign, who recently published a number of sepsis management guidelines. The most recent was published in November 2021. There were several recommendations made in which we see SeptiCyte RAPID having a role in assisting with or complying with these recommendations. The first was the strong recommendation that those managing sepsis programs establish a performance improvement program to monitor improvement in their sepsis outcomes. Multiple studies have demonstrated improvement in bundle compliance and sepsis outcomes with the use of these performance improvement programs. The addition of SeptiCyte RAPID in the sepsis bundle should aid in the early diagnosis and appropriate intervention and bundle compliance. Next. A new recommendation was made against using QSOFA as a single screening tool, but in combination with others such as the systemic inflammatory response syndromes, clinical presentation, modified early warning systems, and other screening processes. SeptiCyte RAPID, with a 1-hour turnaround time, can aid in the early evaluation of a patient identified by these screening processes. One of the unintentional consequences of performance improvement programs, unless closely monitored, is they tend to encourage both appropriate and inappropriate treatment. For example, indiscriminate antibiotic initiation early in order to meet the CMS measures that Dr. Balk discussed with regards to that early initiation of antibiotics inappropriately leading to inappropriate use of antibiotics. The new guidelines recommend continuous reevaluation in patients with unconfirmed infections, searching for an alternate etiology of the presentation of their clinical findings. SeptiCyte RAPID will quickly confirm the presence or absence of a systemic infectious etiology, allowing for early appropriate therapy or evaluation of the patient for a non-infectious etiology for their clinical presentation. This impacts their process with regards to antibiotic stewardship and diagnostic stewardship. Next. A fourth recommendation is that in cases of possible sepsis, a rapid assessment of infectious versus a non-infectious etiology be performed. This performance of differentiation needs to be done in order to initiate early appropriate antibiotic therapy. SeptiCyte RAPID clearly aids in differentiating an infectious versus a non-infectious etiology of these presenting symptoms. Next, the new guidelines and the CMS measures recommend initiation of antibiotics within 1 hour in those patients presenting with suspected septic shock. The 1-hour turnaround time of SeptiCyte RAPID aids in confirming the continuation of antibiotics if the septic score is in the band 4 region, as discussed by Dr. Balk, and would suggest further evaluation for a non-infectious etiology in these patients if in band 1. These patients often are continually treated despite them not having sepsis because of their presentation. In those patients presenting without shock, the septic score would enable compliance within the 3-hour antibiotic initiation time recommended by both CMS and the Surviving Sepsis Campaign guidelines. SeptiCyte RAPID in this case would impact both appropriate antibiotic stewardship, impacting long-term antibiotic resistance problems that we see, and also impact diagnostic stewardship by enabling one to assess the patient's clinical presentation earlier, despite their shock presentation, if they don't have sepsis. Next slide. How do we see SeptiCyte RAPID being used in the clinical workflow? Most hospitals today have typical triage or early warning systems initiated either in the emergency department, where an emergency room triage nurse may have a code sepsis process using SIRS or QSOFA. On the floors, an electronic early warning system is used in some institutions, or a rapid response team process based on nursing intervention may be used. In the ICU, obviously, rounding and nursing appropriately intervenes, and a sepsis early warning system electronically may also be used. This usually leads to a early warnings process where a sepsis bundle may be initiated with directed sepsis lab tests being ordered. We feel that SeptiCyte RAPID needs to be added to this bundle process and included in that order set. Next. The Surviving Sepsis Campaign guideline broadly defines suspected sepsis into 3 groups. The first group is a low sepsis probability, where one is suspicious of sepsis, but no infectious etiology can be determined on clinical evaluation. And the recommendation in this case is to defer antimicrobials in order not to initiate inappropriate antibiotic intervention in a patient who may not have an infectious etiology. A low sepsis probability group with this recommendation, having SeptiCyte RAPID performed, would give you a score either in band 1, supporting the recommendation that you defer antimicrobials and evaluate the patient for further etiologies of their clinical presentation, whereas a band 4 presentation in this group would drive you to initiate antibiotics early in a case with low sepsis probability. Next. The second group of patients is the intermediate group, or the possible sepsis group. And the results of SeptiCyte RAPID would aid in differentiating those with infectious versus non-infectious etiologies for their presenting clinical symptoms, as recommended by the guidelines. This would support appropriate intervention if the patient is in band 4, and appropriate further evaluation and diagnostic testing for those patients in band 1 who do not have an infectious etiology for their presentation. Next, the group that we all initiate immediate therapy for in an attempt to address their presentation is the group that presents with septic shock, who's considered to have sepsis with septic shock as a presenting symptom. Antimicrobials usually are started immediately in these patients, and the use of volume and or vasopressors to address their hypotension. This group is a group who with SeptiCyte RAPID, where the results fall in band 4 with a score greater than 7.4, would confirm their etiology of their presenting symptoms as sepsis and a continuation of antibiotics and further evaluation from a culture standpoint as to the source of the infectious process. Those patients who present with a band 1 presentation as score in this group would suggest that this group does not have sepsis and initiate further investigation for the etiology of their symptoms, perhaps discontinuing antibiotics appropriately and decreasing the use of inappropriate antibiotics in this group of patients. Then you would await culture results and antibiotic sensitivities. In 2019, Prescott published a thoughtful discussion on improving sepsis treatment by embracing diagnostic uncertainty. This slide shows the graphic comparing illness severity versus the likelihood of infection, and the Surviving Sepsis Campaign therapeutic recommendations are circled in red. There are a number of confounding variables that impact these decisions. One cannot always determine the likelihood of infection. The source may not be clear. And depending on the study reviewed, up to 40% of culture negative suspected sepsis cases are non-infectious at the time of discharge. Shock is typically obvious, but other patients falling on the illness severity scale are difficult to assess, and neither axis in this presentation is indicative of the probability of sepsis. Thus, it is difficult to align the Surviving Sepsis Campaign probability recommendations with the appropriate therapeutic intervention. Next. This slide demonstrates how SeptiCyte RAPID can impact this diagnostic uncertainty, with clinical suspicion of sepsis on the y-axis and probability of sepsis as indicated by the septic score on the x-axis. Clinical suspicion is defined as having one or more of the following: signs of systemic inflammation, documented or suspected infection, the severity of illness presentation, and acute organ dysfunction as measured by SOFA or QSOFA due to infection. Next, those patients who present with a sepsis score in band 1 have a low probability of sepsis, driving one to further evaluate the patient's presentation with other diagnostic appropriate tests performed. Those patients who present in bands 2 or 3 with a score between 5 and 7.4 have an intermediate and increasing probability of sepsis and should be evaluated further in conjunction, as demonstrated by Dr. Balk's presentation, with the other non-specific but informative tests, increasing the probability of diagnosis of sepsis in this group by using those tests to raise the score or decrease the score dependent on the test results. And then in band 4, those patients who present in this group have a high probability of sepsis. Initiation of antibiotics is driven by this probability of sepsis. The other tests that we use typically can be used to improve that diagnostic process, depending on where they fall in band 4. But this group of patients has a high incidence of sepsis, as demonstrated by the validation studies discussed by Dr. Balk. Thus, the addition of SeptiCyte RAPID with the increasing septic score and the probability of sepsis supports the patient management guidelines as recommended by the Surviving Sepsis Campaign. Next, I'd like to just present briefly the 2 case studies that demonstrate a possible role for SeptiCyte RAPID in their clinical evaluation. Case 1 is SJ, who is an 86-year-old male who arrived in the emergency department with his family because of decreased mental status and oral intake. Patient lives alone and prepares his own meals. His family states they have noticed decreased intake coupled with increased levels of confusion over the last 2 weeks. In the emergency room, he was found to be dehydrated and confused. Her blood pressure was 80/45, pulse 120. Patient was oriented only to person. Hemodynamically stable after fluid resuscitation, and he was admitted to the floor. He awakened slowly and was being worked up for the etiology of his presentation. Patient's lab tests are shown on the right-hand side, with on day 2, blood pressure improvement. SIRS criteria are met with high heart rate, respiratory rate, mild fever, and a white count that was elevated. Lactate was slightly elevated, but not excessively high. On day 2, the patient had onset of productive cough with some sputum production. Chest examination revealed RAS bilaterally with some bronchial breath sounds, no wheezing. Chest X-ray was ordered, and cultures were obtained for sputum, urine, and blood, and a SeptiCyte RAPID test was performed. Next. At that time, assessment could result in following possible actions. Closely monitor this patient, continue evaluation to determine if the patient has an infectious etiology or not, with no active intervention at this time, pending chest X-ray and culture results. One could assess if this is infectious or non-infectious etiology and consider the antibiotic initiation within the 3-hour timeline, or one could call a code sepsis, begin sepsis order set, and bundles. Next. How would SeptiCyte RAPID impact this action plan? Next, we don't have shock in the case on the second day in this patient, and the sepsis score 4.3 in this patient would suggest a low probability of sepsis. Continue deferring antimicrobial use until these cultures and sputum results and chest X-ray results are present. If that score was in the band 4 range, 9.7 in this case, this would differentiate the patient from showing an infectious etiology for their presentation, and antibiotics could be initiated within the 3-hour timeline, meeting the CMS and Surviving Sepsis Guidelines as recommended. Next slide. Case 2 is a 56-year-old male who was admitted to the ICU after presenting with generalized weakness and nausea. Emergency room evaluation found the patient to be confused with hypotension. He was started on IV fluids and broad spectrum antibiotics with some initial improvement was started. Symptoms, blood pressure resolved, and patient was admitted to the intensive care unit with CT scans of head and abdomen ordered. Chest X-ray was clear, and cultures for sputum, urine, and blood were obtained. On admission to the ICU, the diagnosis of septic shock was entertained. Vital signs show SIRS criteria met. Lactate it was not measured, but liver function tests were abnormal, and urine serum creatinine was elevated, suggesting organ dysfunction. Next slide. On ICU admission, patient deteriorated, remained hypotensive, urine output decreased, CT scans showed no abnormalities. Patient was intubated because of continued respiratory deterioration. Norepinephrine was started because of continued hypertension, and a central line was placed. SeptiCyte RAPID score returned with a score of 3.2, suggesting a non-infectious etiology. Associated with that, an ECG showed ST segment elevations. Troponin concentration came back at 53, which is elevated. This patient went to the cardiac cath, was found to have a complete occlusion of the right coronary artery. A stent was placed, and patient was transferred to the cardiac intensive care unit with uneventful further hospital course and discharged home with full recovery. Next slide. So in conclusion, the SeptiCyte RAPID is the first of its kind FDA cleared gene expression assay. It should be used in conjunction with clinical judgment and other laboratory findings to aid in differentiating infectious positive sepsis from infectious negative systemic inflammation. This is done by measuring the host response to systemic infection in blood. It provides actionable results in around 1 hour. And these results are reported as a sepsis score, as described by Dr. Balk, which correlates with the risk of sepsis. It has a high specificity and a positive predictive value. Gone through this discussion aligning the Surviving Sepsis Campaign guidelines with the use of SeptiCyte RAPID in encouraging ongoing evaluation of systemic infection versus non-infectious diagnoses. It's an additional aid in diagnosing sepsis. It helps in determining antimicrobial administration guidelines, deferring antimicrobials, or meeting the 1 hour versus 3 hour guideline recommendations, and encourages the performance improvement plan by adding SeptiCyte RAPID to this performance improvement plan and monitoring results. SeptiCyte RAPID can improve early appropriate intervention, impacting patient outcomes and health economics. Thank you for your attention.
Thank you very much, Dr. Davis. And now we will move to the question and answer period associated with this webinar. Thank you very much.